It's a real pleasure for me to introduce our next speaker. You know, over the last 3 decades, Joe Flower has worked with a diverse list of health policy stakeholders, both in the U.S. and international. During that time, he has emerged as a leading futurist with a keen sense of emerging healthcare and health technology trends. He has authored a broad range of articles and books. His most recent book, Healthcare Beyond Reform, Doing It Right for Half the Cost, is a must-read for anyone trying to understand the future of American healthcare and the potential pitfalls we must avoid as we attempt to create a true healthcare system in this country that provides high-quality care without breaking the bank. We will have a book signing available after this session, so if you're interested in that book or getting Joe's signature, he'll be right outside afterwards. But for now, please join me in welcoming Joe Flower.
Thank you, Sam. Thank you very much. Good afternoon. Good afternoon. Good afternoon. Thank you. Very good. Very good. We're going to have a good class here. Now, I don't know if you know this, but speakers have a union, and there are union rules. And one of them is you have to use PowerPoint, and you have to use lots of charts and graphs. So, okay, I made a graph. I made it myself. I'm really proud of it, and I'm going to show it off. In fact, the whole talk is based on this. This is why I'm proud of it, not just because I made it myself. It's because I managed to capture in this one graph basically the entire future and the mindset with which we are approaching it across healthcare, all in one graph. So I really want you to take this, and you may want to take notes. Here it is. So, you are here. This is a psychograph of what is going on in the heads of basically everyone who has charge of any part of this enormous industry right now. We are slipping down a slippery slope toward, we don't really know. We don't really know. And I'm talking about the smartest people in healthcare, most connected people in healthcare. We cannot really quite tell where this future is going. So this next hour, we're going to attempt to take a look at that and say, where are we really going? What is the nature of this moment? What can we imagine might come out of it? Now let me unpack this graph for a moment, because it actually does map onto something that professionals like you guys at the CDC put together, people like that who actually know how to put together graphs. Things like this. Now, this is interesting. This is national health spending as a percentage of GDP, right? A lot of wiggly lines. Now, this side of the graph is not surprising. We cost basically twice as much as everybody else. These are all places where you wouldn't have to get medevaced out if you got sick. You know, they're advanced medical economies. What's interesting to me, though, is not this side, because we all know that. It's this side. We always were expensive, but we were sort of at the top of the pack. And then something happened. Kaboom, kaboom, kaboom. What is that? What happened? Now let's see, what year is it? 80, 82, 84? 82. DRGs. The moment that we as a nation said, we have to do something about healthcare costs, we're going to put cost controls in. Kaboom. And you can correlate each of these with further expansions of the DRG type idea across healthcare. Does this make any sense? Is this nuts? It makes perfect sense. Because what we're trying to do is control the cost of the system. Did DRGs cap the costs of the system? They capped unit costs, right? Now, like how much it costs to get a particular, to go to a doctor, to get your knee fixed, whatever, right? They're codes for particular things. Unit costs, we're in a fee-for-service system, so here are the fees. We're going to put caps on the fee schedule. Now, what's that do? If you were Best Buy, let's say, you were in this business of selling flat screen TVs. Now, the market for flat screen TVs is kind of a commodity. You can't sell them for very much. So if you are Best Buy, what do? Hey, pick it up on volume. You've got some entrepreneurs in the room. What else do you do? You, sir, you do not look like the kind of individual that merely needs your flat screen TV. You're a sophisticated person. You need a home theater system with 5 surround sound, and it's going to be the size of a billboard, and it's going to blow people out of them. And it's only $5,472 today. Now, has healthcare done something like that? Now, I'm not saying that everything that we do in healthcare is worthless, not at all. But over the last 30 years, we have not only done increasing volumes of things per person, we have upcoded, and we have found increasingly complex things to do for the same problem. Going, for instance, in an extreme example, from medical management for back pain to complex back surgery, multi-point, doing the entire spine, every abnormality, for the same problem and with the same outcomes. So, yeah, we are in the position of Best Buy. We're finding more and more things to do that cost more money, more per person, and more people at the same time. But what about the other side of that curve? So this is kind of the first side of my curve. And whatever part of healthcare you're in, every business model, every revenue stream, every personal career in healthcare is pegged to this graph. Every expectation, every capital program, every program development is pegged to that expectation. What's happening now? Healthcare spending in the U.S. in 2011 grew at one of the slowest rates in 50 years. The growth of health spending has slowed substantially in the last few years. Interesting. Healthcare inflation is leveling off, coming down. And there are lots of economists saying, well, we're in a recession, it's cyclical, this argument has worn a little bit thin as the recession has stretched from 2007 into the present, and this trend continues down as the economy begins to pick up. It does not track with the recession. There are other economists that are looking at it very closely. What are the kinds of utilizations that are not coming in? Where is it dropping off? And they come to a different conclusion. They're saying, slower growth in Medicare spending, is this the new normal? New England Journal of Medicine. They have their own graph. They're a little more professional on it, and they're tracking this, but this needs a little more explanation than mine does. They track, this is the rise in GDP. So they control for the rise in the overall economy, and they compare it from 1975 to up forward with the rise in healthcare spending per beneficiary, right? Now you can see, first thing you can see is it's all over the place. Second thing you can see is there's a general downtrend. And after, as soon as we got Medicare, it's like, whoa. But there's something very interesting. It's a general downtrend, and then you get to 2005, and it looks like a ski slope. And their projection from their analysis of what kinds of utilization are dropping off is that it's going to go negative to the rise in GDP, and it's going to stay down there. Now, if every business model, every personal career, every program development is pegged to that first graph, this is why we are all feeling like this. Because they are compressing. So we really need to look at what is the nature of that, especially if, as I can assume from everyone in this room, for the nature of this conference, that we are all dedicated to how do we really help people become healthy and stay healthy. Long life, little suffering, good death. And we are here for reasons that are more than just it seemed like a good idea at the time. We are here for reasons that deeply have to do with who we are and what we're trying to do in this world. This is very important that we try to figure out what is going on. Because we are here, and we're advancing into something I'm going to call the next healthcare. The next healthcare, by its very nature, is a vastly more complex ecology. There are shifted incentives and risks for everybody all across healthcare. By nature, it has to be more efficient, more effective, more upstream, close to the customer, in their lap, in the customer's purse, on their iPad, on their iPhone, on their Galaxy, or whatever, in their house, in their ear. This is like you were talking about. How do we move into people's lives? It has to be that way in order to work at all. And we're used to a sort of a monoculture in healthcare that we sort of all do business the same way, mostly. We get some outliers like Kaiser, but we mostly do business one way. What we're going to see is a wild proliferation of different ways of doing business, different modalities, different ways of reaching the customer, new people in the field, and it is a tough fit for everyone who is in healthcare now. Now, what's driving this? Why are we? Well, obviously, reform is a piece of it. It's obviously a piece of it. But reform does not cause the change. Reform is more of a catalyst, more of a spark, helping shape things somewhat, laying out new rules for people, laying out new possible revenue streams. It is a spark. It didn't cause it. It was caused by economics, demographics, and technology. We'll take a look at these. One of the big things about this future that we're facing is the great strategic uncertainty. Now, this is really interesting. Well, for example, I talked to, the other day, I have an acquaintance, I serve on a board with him, who is one of the world's, he works for one of the world's largest banks. I can't tell you exactly who it is, but he works for one of the world's largest banks, and he is at the executive vice president level. He is the guy for that bank in charge of aggregating capital for healthcare. Now I'm thinking, this is somebody who has a very interesting look at the future. There's policy, and then there's where's the money going? And what are they spending it on? And he told me something very interesting. He said as of about as little as 2 years ago, when he first passed healthcare reform, 5% of his business was to mergers and acquisitions. Most of it is somebody wants to build a new building. We want to build a new campus, something like that. We need to sell some bonds. Today, 65% of his business, from 5% to 65% of his business, mergers and acquisitions. Wow. I said, who's doing this? Well, one thing to note is a lot of for-profits buying up whole groups of hospitals from not-for-profits. I think it just happened in Kansas City with HCA, right? That pattern is duplicating across the country. Rapid expansion of for-profit chains. The other thing that is very obvious is that large chains of all types, these are not medium-sized groups. The big chains are getting rapidly bigger. People like Dignity, people like Ascension, people like Christus. Notice a lot of these are not-for-profits. In fact, a lot of them are religious, Catholic, exploding like crazy across the country. But the third thing that is really interesting is that they're doing with all these different strategies. They don't have one strategy. Dignity just decided to spend $500 million expanding into occupational health across 20 states. What this says to me when you see all these like really smart people spending large amounts of money and they're going in different directions, to me that says that nobody really has a handle on just what is going to happen. What will be a revenue stream that brings the money? How can they make money? Now, what is useful to know about this, and we will return to this, is he says, I said, is this a revenue play? They think they're finding new revenue streams? He says, no. It's a cost play. They believe they can drive down costs. That's why a for-profit chain would buy up not-for-profit hospitals. They think they can do it better. Very interesting. Now, we're also facing, by the way, I don't know if you've noticed this, we're having an election in 2 weeks. Is anyone? Oh. Let me say one thing about the election. It's a nonpartisan thing to say, in that I've been getting calls from various media asking me, well, you know, it's obvious that at least the business community believes that Obama's election is going to be a disaster for them, and Romney's election would be good for them. Well, I'm not a business analyst. I'm a healthcare guy, and I can tell you that in healthcare, it's exactly the opposite, because the entire industry has is resettling in, okay, we're in this kind of new environment. We're moving in this new direction, of which Obamacare is a piece, and it is heading that same direction. And it is the settled law of the land. There is arithmetically pretty much zero possibility of it being repealed. You'd need 60 votes in the Senate. So if Romney is elected, what we're going to get is a party, and if the Congress remains mixed, as it likely will, what happens is we have a party in power that is against the settled law of the land, and so they're going to be like defunding it, they'll be giving waivers to everybody, and basically creating a lot of difficulty around it without being able to get rid of it. So, and if Obama is reelected, you have an administration that's full on moving forward in the direction we've been moving. So for the healthcare industry, a Romney election represents more strategic uncertainty and more chaotic change, whereas an Obama reelection represents going further down the road we're going, which is hard to figure out, but we're already moving that way and people are beginning to figure it out. Along with this, we have this fiscal cliff of, hey, I'm a futurist. I can see what's going to happen, right? You know? So this fiscal cliff, which is basically, if you haven't been following us, the Congress gave themselves a huge tripwire full of things. Basically, nobody on any side of the political spectrum would vote for this to happen. It cuts all kinds of things in a kind of random, chaotic way, and it cuts everybody's favorite child all across. And their assumption was that this was such a bad tripwire, it would cause them to change it before it came into being. They have a much higher opinion of their own abilities to get something done than I do, and than most people out there do. Most people think we're just going to drive right off this cliff. Two things to know about this. One is that the actual implementation of this fiscal cliff stuff is not sudden. It would dribble out over time as different budgets come due and as different things get. The psychological tripwire, though, is huge and sudden, and it may have an enormous effect on the U.S. economy and, in fact, on the global economy. There is a possibility of driving the globe into another global recession by doing this. So this is way stupid. Guys in Washington, don't do it. And for healthcare, obviously, it just increases the strategic uncertainty, the idea that we really don't know where the money's going to come from or if it's going to be there. So a big part of this future, I'd already talked about this a bit, is consolidation. The industry is going to consolidate. It's going to consolidate into for-profit chains, and it's going to consolidate into mega providers, whether for-profit or not for-profit. And we're going to see, as I said, a wild proliferation of business models and strategies. And in some areas, like Dallas-Fort Worth, you get one group that is buying up all kinds of practices and buying up hospitals. You got somebody else who is just allying, doing joint ventures all over the place. A part of this is because nobody can figure out how to manage doctors. Doctors don't like to be managed, basically. They don't even like to be managed by other doctors, but they at least prefer that to being managed by somebody, dressed like I am. And so there's all these different strategies of how do we do this? Joint ventures? Do we set up councils? And it's very confusing, very difficult. Now, one of the things that's important about this, it's very different, that makes this actually possible is that we have the data. We have an ability to see into healthcare and how it works and what doesn't, that is far beyond what we have had before, and that actually allows these kind of changes. These kind of changes would simply not have been possible even 5 years ago because we were still aggregating the tools. 20 years ago in the Clinton era, don't even think about it, not going to be there. Now, I do have to mention one important factor in this future is the chronic disease, which accounts for some 70 to 75% of all healthcare costs. Now, I know you've heard a lot about this, and you're going to hear a lot about this at any healthcare conference. I want to make a few points about it. As a futurist, you look for markers. What's a marker for the future? Well, I think the best marker for the future of chronic disease is obesity for several reasons. One is easy to measure, right? You either are or are not at a body mass index of over 30. You can measure that with a population. You can see it's there. The second thing is that it takes decades to unfold. So if you are an obese 18-year-old, you're going to have serious health problems when you're 38, 48, 58 if nothing changes. The third reason is it ramifies into many diseases, not just the ones you'd think of, diabetes and cardiovascular disease, but things like various types of cancer. And Alzheimer's disease is now coming to be called diabetes type 3, which is really interesting. It seems to be related to metabolic syndrome and to the uptake of sugars and such, which is like wild. So that means if you follow the past of obesity, you can see something of the future of its impact on health in this country. And I'm going to do, these are actually modified from the CDC. I'm going to show you some maps. People are always asking me for this series of slides. I say, go to the CDC website. They're great. They're amazing. But take a look at this time series. The darker the color of the state, the greater the percentage of people in that state who have a body mass index over 30. If you see a blue state, a dark blue state, that's more than 20%. If you see a red state, that's more than 25%. If you see a dark red state, brick red, it's more than 30%. So here we are in 1985, 1991, 95, 97, 2001, 2004, 2006, 2007, 2008, 2009. You see Missouri finally fell into the brick red there, didn't you? This is a big problem. This is vast. It's huge. It's spreading. And it's harder because we don't actually know exactly what causes it. We tend to think we do, but we don't really. And we also don't exactly know what we could do to end it. Again, we think we do. We all tend to think we could tell fat people to just smarten up and, go do some exercise or eat smarter. I don't know. If you've tried to lose the same 25 pounds over and over again like I have, it doesn't work. So this is a very, very intractable problem. It will be a big part of our future. Now, what does all this mean? I believe I am seeing across healthcare 5 shifts. Now, these are not Joe Flower's ideas for how we should do things right. There's a whole industry of people writing about how we should do things right. This is more what I've seen happening, that if you think about it and see how they work systemically and begin to work together, you can see as these things progress and come together systemically, we will see a transformation in healthcare unlike anything we've ever seen. These 5, I'm going to go over them quickly and then slowly. These 5 are explode the business model about fee-for-service, right? Build on smart primary care. Put a crew on it, swarm the customer, and rebuild all processes. Let's take a look at these. What do I mean by explode the business model? Well, we're used to a business model that actually has 3 parts. It is commodified, insurance-supported, fee-for-service. Commodified, you cannot shop for value by price. I've done this. You call up in sophisticated markets like Atlanta, the Bay Area, you can call up and you can find some unit of healthcare that is pretty much, it's pretty much that you can get the quality you want and it's pretty well defined. I like to pick a cardiovascular stress test. They put you on the treadmill, they wire you up, and they do all, okay. How much would it cost if I just come into your office and get a cardiovascular stress test? You call 10 different places, you get prices from $500 to $5,000 for the same thing. Can you think of another product you can buy basically the same product for 10 times the price as an individual? This is a broken economy. So there is no incentive here for me to figure out what the quality is, especially because someone else is paying for it. It's insurance supported, right? So you disconnect the customer from the person choosing it from the person paying for it. And, obviously we need insurance. We can't just pay for it all out of our own pocket, but somehow we have to be in the game. We have to become smart shoppers, and we have to have the incentive to do that. And fee for service, I'm not buying what I want to buy. I'm buying make me healthy, cure me. I'm buying help me manage my health. That's what I think I'm buying. That's not what I'm paying for. What I'm paying for is items off a list, and somebody else is choosing the items, right? So the two do not necessarily meet. I don't need a complex back fusion surgery with everything in it done for $68,000. It turns out maybe what I need is medical management, a few NSAIDs. I'm not a doctor. I'm making this stuff up. But for $600. But it's someone else that is essentially choosing that. So these three things together, when you begin to knock the pins out from any one of them, even partially, it doesn't have to be wholesale, we're not all going to become Kaiser or something like that. You begin to even partially change some of those so that the system begins to get different feedback in it, and suddenly everything changes. Everything changes. Your revenue sources are different if you're running a system. Your workflow systems have to be different. Your business structures have to be different. You begin to go out and buy other people or make joint ventures or something, because the old way that we have structured healthcare doesn't work under these new business structures, these new revenue sources and such. So your physical environments change. Where are you doing healthcare? All of a sudden you're doing it in schools and in malls and on people's phones. Your relationships within your organizations and between organizations change. Your data flows change. You need to know vastly more and different things than you did before. And the note to self is that all of this happens at the same time. This is, well, as the Chinese would put it, the most interesting time to run any kind of healthcare institution that we have ever seen and that likely will ever see. I do believe that if I live to be 90 or so, we will all be looking back to this time right now as this kind of hinge point, like in my graph, in which healthcare became something entirely different that we're not used to. Almost everyone in healthcare is looking at this, and their big concern is they're going to be cut out of the market. Somebody's going to come in and steal market, and this is a legitimate concern. Everyone is at risk of not existing anymore. So you're seeing all these new structures. One thing to notice about them, I mentioned before, when you're looking for allies and partners, a key thing is the doctors. So you're seeing a lot of these structures, it's like there's this sort of hole at the center of healthcare, and the ACOs in the ACA. I love talking about it like this. You know all the acronyms, right? The Accountable Care Organizations in the Accountable Care Act are a description of filling that hole at the middle of somebody being sort of really responsible, accountable for the care and feeding of the patient. That hole has been empty. Everyone is now trying to rush into that hole, not necessarily to be ACOs. They may be something different. They may not actually fit the legal definition, but that's recognized that that is the place where you actually can drive down the costs of healthcare and drive up the quality, do it better. So everyone's trying to rush in there, and they all want to be in charge of the team because that's what feels good to them. So you get these new structures that are hospital-centered. Most of them are hospital systems trying to build them, but you also get a lot of physician-centered where there are large physician groups that are saying, no, we're going to take this center space and we will contract to the hospitals and to ambulatory surgery centers and to labs and such. And you get joint management tried. It's very difficult, but they're trying that. So there's all these different ways of doing it. At the core of all of these, though, is the notion that we're likely to see the end of cost shifting. This is, well, when you give a talk like this to a room full of hospital CFOs, the room gets very quiet. This notion. This is the basis of hospitals for time immemorial. This is the way they make a living. They transfer revenues from things that pay them more than they need to things that pay them less than they need. Increasingly, the large systems will be competing with other people that are doing the same thing, the back pain management, say, or the birthing or something, that are doing it at a much lower cost structure. So they're increasingly not going to be able to do that. They have to compete each type of thing they're doing directly with others doing the same type of thing that have a much lower cost structure, which means, among other things, they really have to upgrade their cost analysis. One of the things that just blew me away when I first got into healthcare writing in the, I think there were still dinosaurs roaming the earth at that point. Setting my little clock here so I know what I'm doing. It was pre-DRG, I'll tell you that. And I went to, I'd come from business writing, and so I was learning all about healthcare, and I was actually really proud that I could pronounce the word cholecystectomy. I was talking to a hospital CFO, so I had to chart out my word. I said, so, how much does it cost you to do a cholecystectomy? His answer astonished me. It had nothing to do with cholecystectomies. He said, we don't know. Why don't you know? Well, because we don't produce a cholecystectomy. We provide the operating room, we provide the nurses, we provide this and that, and then there's an anesthesiologist who bills separately, there's a radiologist, there's boom, 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 all this stuff happens. They all bill separately. Nobody knows what the whole thing costs. Wow. I immediately, this is like one of the first things I was writing about in healthcare. During the Carter administration, I immediately said to myself, the question that has occupied me the rest of those years, how can an industry survive when it doesn't know how much it costs to produce its effects? How is that possible? And we're getting to the point where it clearly is not possible. And so we need to upgrade the cost analysis per unit of sale. The unit of sale is increasingly the outcome, that is the birthed baby, the controlled diabetes, the replaced hip, not the operation or the procedure or the test. Per outcome, you need to know your sunk cost, how much does it cost you to build that operating room, your incremental cost, how much does it cost you to do each next procedure, and your risk cost, how much does it cost you for the fact that you sometimes don't do it well, and it comes back to haunt you. This is increasingly a problem, obviously, in healthcare, and even more so for the big systems, their institutional costs, that huge premium that institutions layer on because they're big and they're complex and they have, it's a big, complex thing to do. But increasingly, the market is not buying the argument. Yeah, you're big and complex, but why should we pay you more to birth the baby than somebody down the street? So this is huge. This is, you could tell hospital CFOs because they sleep like babies. They wake up every 2 hours and cry. This is not a good time to be in this business. In fact, I'm seeing increased rates of early retirement among hospital CEOs and CFOs. What we need to do is to be able to take that cost and drive it much deeper, down to the individual patient and case level. Most costs in healthcare systems are averaged and allocated. That is, in general, we got this amount of cost, so every department gets this amount, so you put this amount in every operation. We don't find out anything when we do that. And we need to turn our organizations into deep learning organizations. So you need to drive the cost to the individual patient and case level. We need to be able to answer the question, how much did it cost us to replace Mr. Herndon's hip? Not an average hip, Mr. Herndon's hip. So that if somebody discovers some way, they try something different, that we could do it for less, more effectively, more efficiently, we're able to actually notice that. As our cost systems now, we can't even tell if someone does something better or for less. And aggregate those up, how much does it cost this integrated practice team to replace a hip? If they find, on average, they are able to do things somewhat differently, for less, we should be able to know that. Right now, we don't. And again, how much does it cost for this whole integrated practice unit, like say a spine and pain center, or a birthing center, or a diabetes team, to do each of the things that it does? Now, one of the things to notice here is that if you're going to do cost structures this way, you have to have integrated practice units. People who stay together over a period of time and do the same thing over and over. And you have to have dedicated teams. Most of healthcare does not have that. They trade people out from one shift to the next, from 1 month to the next. They rotate people through systems. People do not work together in teams over time. It is not possible in most of healthcare to ask, could we do this better? Because they're not the same people. They're not working as a team. So you change the structure of healthcare just to try to figure out your costs. Now that's the cost side. The revenue side is even more complex. You been in this class? Let me run through this because it's actually pretty interesting and pretty challenging. The old-style fee-for-service works like this. Now, I know this is kind of basic arithmetic to everybody here, but we need to kind of think about this a bit. You have your office visit procedures, everything has a cost, and you add them all up and you put them in the health plan black hole. And if you're lucky, they come back with revenue. And okay, so you ask yourself, all right, am I making money yet? Well, that's not the only payer. There's other payers, and they have their own lists of prices. They got their own black hole, and they come back with their own amount of revenue. And then there's the CMS people with Medicare and Medicaid. They got their own lists and everything like that, and you go, okay, how about now? Now am I making money? Well, there's complexities here. There are people who have supplemental insurance with Medicare and Medicaid and other insurance. There are people who are dual eligibles with Medicare and Medicaid. There are people who walk in and put down their credit card, or at least claim that they can pay, self-pays. So, how about now? Well, maybe. One of the things to notice here, this is kind of complicated, but it's not mentally complex. That is, all of these incentives are headed in the right direction. They're headed in the same direction, let's say. As long as you can do your office visit, if you keep the cost below what your reimbursement is, you're making money. You add up all these little things where you're making money, and you get revenue. When you go to the new hybrid payment systems, now, like I said, we're not all becoming Kaiser. We're layering in new types of payment structures on top of, right beside, worming through the old ones. So, and there are many more of them than I'm going to show here. I'm just going to give a few examples, but these new ones, their incentives run at cross purposes to the old ones. So you get these prospective payments, say like for a medical home, and there are different ones from different payers, and some of them don't pay you that way. You get these quality pay for performance bonuses. You get these savings kickbacks, like if you save Medicare a certain amount of money, they will kick something back to you if you're an ACO. And okay, say, okay, now we're making money, right? But keep in mind, the more you do this, the more you do the quality for performance things, and the more you do you save money, you're getting less of these things. You're getting less operations, you're getting less people in the emergency room. That's what we want, but that's your revenue, right? I mean, just last week I was talking in the Toro Children's Complex down in New Orleans, and the CEO stood up and said, now, can you explain again to me how I make money off an empty bed? And the answer is you don't if you stay in the old business model. If you stay in the old business model, that is slow death. Because everything you own, everything you get with these new business models, these new revenue streams, costs you money from your other revenue streams. But, okay, are you making money? Well, now, wait a minute. This may look one way on the budget, but as cash flow, it looks different because a lot of these things, especially these bonuses and such, there's a delay in getting them. So what you do today, what you spend money to do today, you're going to get a payment for it maybe 6 months, a year, 18 months in the future. And then there's more complexity because you have to reallocate costs and revenues across the network. You're doing all these joint ventures, working with all these partners, these new allies you built. You've got to figure out how do you reallocate this mess all across that network. And so it's like, okay, someone's making money, but who? So this is a big part. The revenue side of this is a big part of that strategic uncertainty that is plaguing healthcare plans about the future. And this is why all of those expansions I'm talking about are cost plays, not revenue plays, because the revenue side is so uncertain. But the cost side, they can see clearly we can drive down these costs if we're really smart, and we think we're really smart, and we're the big guys on the block. We got all these systems and everything. So we can drive down those costs. The revenue side is like, ooh, we don't know. So we drive down the costs enough, and we'll be able to make money no matter how we make it. So the second part of this, though, is you have to build it on smart primary care. And the emphasis is on smart because there's not enough doctors to do it the stupid way. And you don't get the benefits if you do it the stupid way. And the keys here are move fiercely upstream, as I said, and experiment. That is, this is much more important than standardization. Measure what you're doing, improve it some way, try the improvement, measure it again. This is not a habit we have in healthcare. We have to get in this habit. Let me give you an example of what I mean by a smart primary care attitude and system and what difference it makes, okay? This is called the Vermont Blueprint. This was something that Vermont tried on a few primary care practices, large ones, and it worked so well they spread it out across the state. You know, in the People's Republic of Vermont, they do things that way. So what did they do? They took what was already advanced medical homes. You know, they had the patient registries are all digitized and all that kind of stuff. And they had those kind of pay-for-performance bonuses and all the stuff that's a medical home. They added to it a 5-person care team. They included people like a nurse health counselor to help people understand their disease process better, community health specialist, help them find the bus and help them figure out their insurance, these kind of things. Behavioral health specialist, because behavior drives most of physical health problems. The public health outreach, all this, 5 people, okay? What did this cost? In Vermont terms, it might be the same in Missouri, I don't know. It wouldn't be the same in California. You could hire 5 professional people for $350,000 a year. They could cover 20,000 people. Because, of course, most people don't need any help, right? Do the math on that. $17 per person per year, and what do they get? For $17 per person per year. Now, the technical healthcare economist term for this is bupkis. Nothing, right? It's like, it's lost in the noise. $17, and what you get is ER costs are down 36%. Their overall costs are down 12%. Is that big? 12%? There's a general population, old people, kids, working people, right? How much does that, in percentage terms, how much is that? When we were arguing about trying to insure all uninsured Americans, do you remember the number that was bandied about as being like just too much, we can't cross that line? What was the number? Come on, were you guys there or not? $1 trillion, right? Obama laid down a mark and said, I will not go over $1 trillion. And people are like, $1 trillion? And we can't afford this. Okay, $1 trillion. Excuse me, but I work in healthcare. I'm not impressed. It was $1 trillion over 10 years, $100 billion per year. This is a $2.7 trillion industry per year. We're talking about 4% of the spend is what it would cost to insure all uninsured Americans. 4%. And here for $17 per person per year, you're getting a 12% drop in the spend. 3 times the amount it would cost to insure all Americans. And just giving you a sense of the scale there. There's other programs like this, Blue Cross Blue Shield. You may have heard a whole lot about this. I find this fascinating. Alternative quality contract. Works like this. They go to a bunch of primary care docs, have to have at least 5,000 Blue Cross Blue Shield primary care patients. And they go to them and say, now, you don't know how much these people spend in health care, overall. We do, because we pay the bills. Right? So, we take the last 3 years, average them out, and we do some statistical things to get a good number. And we say, that amount that they spend on all of healthcare, that's your budget, okay? Now, at the end of the year, you keep billing us like normal, but at the end of the year, we're going to come and we're going to settle up. Anything that they spent in an emergency room, in a spine and pain center, and a neurologist, in a surgical suite in a hospital, we're going to back that out of your budget, right? So, we're not giving you gatekeeping ability. You can't tell them that they can't go to a neurologist or something like that. What can you do to keep them from spending money that would be yours? You can take really, really good care of them. You can call up all those diabetics, see how they're doing. You can find ways to connect with them. You can get really close to your customers. There's lots of things that you can do if you're really incentivized to do it. Well, this is really interesting. They're paying these guys to bankrupt these guys. Well, not bankrupt them, but to drive down the amount of cost that is spent unnecessarily in emergency rooms, surgical suites, things like that. And this actually worked pretty well. They've been doing this for 6 years and slowly expanding the program. And as they go forward, it's a long-term, running contract that rolls over. They work with them every year, and they ratchet down the total amount. Otherwise, these doctors would be like making all the money in the world over time as they drove the cost down. Because it may be as much as half the cost in healthcare that we could drive out of the system by being smart about it. So they ratchet down the amount, making sure these doctors are always making good money by doing really good things to keep their customers from having to go to the emergency room or into the surgical suite. So I find that fascinating. Now, one of the things you find as soon as you go into this type of healthcare is you have to put a crew on it. It is beyond what the individual way of doing old siloed healthcare doesn't work to drive down these kind of costs. Now you have to drive the risk to the operational level, as they did with this Blue Cross Blue Shield of Massachusetts. That is the people actually affecting the business, The people actually affecting the customer have a stake in it. I'll give you an example. This is how you make a team. The scoreboard makes a team. I'm a Giants fan. I'm from San Francisco. Have you been watching these games? I know that the Cardinals lost. The scoreboard makes a team. Right? I'm only a Giants fan when they're in the World Series. The rest of the time I ignore them. But a team is a group of people who are dedicated to putting the same numbers up on the same board. In most of healthcare, that's not true. You get people working side by side who have somewhat different incentives. They're driven by different things. Not all of which is money, by the way. But they're driven differently. And they're not actually working to put the same numbers up on the same scoreboard. I'm going to show you an example of what happens to a system when you convert from one to the other. And these numbers are, well, they're pretty spectacular. This is from the Alaska Natives Health Service. In 1975, Congress said something pretty interesting. It said to Native Americans, we provide all these services for you. We think we should continue to provide the money, but you should manage them, including health care. When you get the institutional capacity, you get it together to manage this, we're going to turn it over to you. Alaska Natives did this in 1998. They got some nice new buildings and everything like this, but they got some spectacular changes in their numbers. Now here's what happened. They decided they're not just going to get new buildings and such and do healthcare the same way. They asked themselves, how would we do healthcare differently because we're a tribe? Because we are Alaska Natives, because we have certain family values, because we like to work together and all this sort of stuff, because we come from these little villages, all this sort of stuff. How would we do healthcare differently? They changed their system, and I'm going to show you the results. They got here's when Native ownership began. They put the system in place, and they got a 50% drop in ER and urgent care. They got a 40% drop in hospital admits. They got a 60% drop in specialist use, a 70% drop in pediatric asthma admits, which is a big deal up there. They got a 20% drop in primary care visits because they worked it out. You don't have to come in for a visit. I can talk to you on the phone. I can Skype you, on your phone. Their HEDIS scores were at 75 to 90th percentile. Their satisfaction rates consistently over 90%. Pretty amazing, right? What was the key difference? The key difference was, the key difference was not on a slide. The key difference was they put together these teams, doctors, and then a number of, kind of like the Vermont Blueprint thing, and they put each team was in charge of a panel of maybe 1,200 patients at the primary care level, and everybody gets a base salary, but then they get the bonuses, large things that actually make a difference. Bonuses, advancement, everything you want in your career is dependent on the rise in health scores of that panel of patients. You make them healthier, you do better. And these are the results they got. So in order to do this, they, like anyone else, has to swarm the customer with ideas, with information. Well, one of the things to ask, now this is kind of obvious, right? One of the things to ask is, who do we swarm? There's an idea about targeting. You get different results from swarming different groups of people. I was involved in I don't mean to insult CDC right in front of them, but there's something, we found out a lot from the AIDS epidemic. I was involved in the AIDS epidemic thing in the San Francisco area in the 1980s when we were struggling with it. And one of the questions was, you have information about safe sex and this kind of thing. Should you target or should you spread it wide? Now, I think for political reasons or something, the CDC was on the let's send it everywhere type of information. Let's blanket the population. Whereas those of us who were more sort of, our friends were dying, we were like, no, let's put it in the bathhouses, and let's get the bathhouses closed if we can. Let's put it in the bars. Let's put it in the organizations that are key to the gay community in San Francisco. And those worked, and we actually got some very interesting statistics on the uptake of the information by targeting it. So this idea is that there are different parts of your population that you can affect differently or that have a greater return on investment. There's a Pareto rule in healthcare. Am I wrong about that story? You remember that?
No, a lot of it also, we evolved as we made local decisions.
Yeah, yeah. The local decision-making was an important part of that. I know that CDC was not like antagonistic. They just had a different strategy. And at the School of Public Health in Berkeley, we actually brought in some CDC people, and we brought in some people. The guy who built SimCity came in, and I was part of what we were talking about there, that you could actually affect a system sometimes by tweaking a small part of it. The Pareto rule is, you may know it as the 80-20 rule. 80% of your effects come from 20% of your inputs. So you get 20% of the people generate 80% of the cost in healthcare. 5% of the people generate 50% of the cost at any given time. 1% of the people generate 20% of the cost. Now, this is really interesting. Who are those people? Now, some of those people just got hit by a bus, or they just got pancreatic cancer, right? It's their year to be expensive. Most of us in this room are not expensive this year. But there's a significant proportion of those people that are in the same category year after year. Those people are not getting hit by a bus every year. They have untreated chronic disease. And you can affect that. You can do something about it. So the rubric here is find the 1%, find the 5%, help them be at risk for their costs. So if they cost less, it's good for you. Put a crew on it and lower those costs dramatically. There are several examples of this. I'll just go through quickly. Boeing has an intensive outpatient care program for their top 5% of people who have multiple chronic problems. They have a medical home model, a team care thing they put on to kind of bombard these people with extra help. After a 30-month test, they concluded they got a 20% savings. Now, keep in mind, follow the arithmetic here. The top 5% of people generate 50% of the cost. If you're saving 20% on the top 5%, that means you're saving 10% on the whole group. You save 10% on all your healthcare costs just by focusing on the top 5%. Similarly, Atlantic City, there is a union that supplies workers to the casinos and to Atlantic Care Medical Centers. So you've got croupiers and nurses like coming into the same clinics. They established a special care center for the top 5% of their healthcare users, and what they ended up with, this was like really focused on these users, calling them up and talking their language. A lot of the lower working groups speak Gujarati, so they got a Gujarati person on staff. And what they were able to show is that they could drive down the ER and hospital cost by 40%, the overall cost by 25%. And again, the top 5% of users are 50% of the cost. So this is equal to 12.5% savings on the entire group, equal to the savings in the Vermont Blueprint thing, but here they're only focusing on the top 5% of users. So the question is to move fiercely upstream and to experiment, to measure, improve, try, and measure again. Finally, you have to rebuild all processes. I'm going to move through this part quickly because we're a little bit late on your schedule, but basically, none of this stuff can get done with the kinds of processes we have in healthcare that we're used to. We have to build new processes, and we have to rebuild them continually. What do you measure? You measure everything. But the suggestion is, there's a great book, it's not reinventing, Reengineering Healthcare by Michael Porter and Elizabeth Teisberg, 7 years old. But it was the best analysis of competition in healthcare I've ever seen. They talk about measurement. You measure everything, but these are kind of the minimum. You measure patient medical outcomes, outcome measures, complications, errors, failures. We tend to want to not notice our failures and our errors. Diagnostic accuracy. How often are you wrong? Patient registries, patient feedback. Did they like what you did to them? Your cost, obviously, by activity and by over the entire care cycle, which we don't usually measure it that way. And what is the experience? I was just down in Abu Dhabi helping them with their state system, and they have a lot of problems. One of them is they have doctors doing hearts who do 12 hearts a year. I mean, excuse me, this is like Tiger Woods only practicing golf on the weekends or something. I don't want somebody touching my heart unless they do at least 200 or 300 of them a year. So what's your experience? What's your volume? What are your methods? What are you doing differently? And what are your patient attributes? If you don't measure it, you can't improve it. If you don't make it seamlessly easy, seriously easy, it's not going to get done. So there's a number of other ways in which we need to redo the processes of healthcare to do something entirely different and new. Your revenue cycle management, your data, it goes way on an EMR, to using big data to drive the system, using things like sentinel surveillance to tell what's coming, infodemiology. This is something the CDC really does a lot. I just love this. Let me give you an example, actually, from the CDC of infodemiology. There's a thing called Google Correlate. I'll spend a little moment on this because I just love this. If you can take any time series, upload it to Google, and it'll find what series of Google searches exactly match your time series, right? So CDC went, oh, this is cool. Let's upload time series of biodata. So ask yourself this. When, say, flu hits a city, or like you were talking about whooping cough, what's the first thing that people do? What's the first thing that shows up in some way that you could measure? It's not the emergency room. It's Google. So here we have, the blue is the unspecified site, acute URINOS, and the red is the searches for Tylenol and cold. See how they match? So if you were running this, you would be able to see, oh, here we are in Atlanta, and boom, oh my gosh, there's going to be a raft of people coming into our emergency room like in 12 hours when it gets really serious. This is called biocorrelate, and it's an example of being able to use the data to find out what's going on out there, or to put them into geographic information systems to see where the people are in your community that are providing, where do most of the ambulance calls go, for what types of things, where are most of the infectious diseases coming from, where are the people who are making you the most money coming from, where are the people that are costing you the most money coming from, how can we deal with those different populations? Geographic information systems, population explorers tell you who the 1% are, who the 5% are. When you look at these things, these 5 elements that are emerging across healthcare in different pockets and ways, and they are each on an upward trend. And you begin to see how they interact with one another systemically. You can see a very different future for healthcare. If you look at exploding the business model, building on smart primary care, putting a crew on it, swarming the customer, and rebuilding all processes, these things working together in a complex system, a complex adaptive system, become positive feedback loops. They influence one another, and over time the system gets leaner, smaller, smarter, cheaper, better, half the percentage of GDP, half the cost per person, half the cost, better. This is the vision of healthcare beyond reform, doing it right for half the cost. Thank you very much for your time this afternoon.
We'll go ahead and take about 5 minutes for some questions, just real quick. So if we have some, please let me know.
Does anybody have any questions left after I've answered everything in the whole world? Yes, ma'am.
Wait a minute.
Can we get her
Yep. We're getting her a mic.
We have our microphone runners here. There we are.
Go ahead, Mari.
My question has to do with as healthcare providers become more savvy about their patients' attributes and are trying to reduce costs, what impact do you see that having on the selection of patient populations, and who will that leave out in the cold?
Well, a couple of things. That's a very interesting and very savvy question. What happens with the selection of patients if you can select for like patients who are healthier? Well, there's 2 things to think. Well, there's probably lots of things to think, but I can think of 2 of them. One is, like the Alaska Natives, they're not getting compensated on how healthy their patient population is. They're getting compensated by the improvement in their health. So it might drive them to, if they can at all influence what patients they get, they might drive them to try to get patients who have something that they can improve a lot. You know, like diabetes is fairly more malleable than, say, Alzheimer's. That's one thing. It depends to a great degree exactly what you're incentivizing people to do. Another thing to think is, you know, they are limited in their ability to choose, especially now if you have a must-carry provisions in the law. But a third thing to think is that a number of, I gave a couple of examples, there's many examples across healthcare where they're saying, we're going to establish special centers for people who are difficult, who have the return customers for some reason or another, for people who we're constantly seeing in our ERs. There's a number of systems across the country that are doing this. And so, and the doctors who work there, they have that panel of patients. They have the patients who are, or the patients who are, they have some unusual condition, some unusual disease, which causes them to be very expensive. Ideally, in a system like this, those people, those different groups of people should have different clinicians, clinicians who are really adapted to and incentivized to take really good care of people who are on that long tail. And we shouldn't, ideally, you should not have a, say, primary care physician have his entire practice upset because he has one or two people who have very difficult diseases or intractable chronic conditions or addictions or something like this. They should be able to export those patients to people who are really good at taking care of that kind of patient.
Time for one more question.
You thought we had time for 10 more questions, but then I answered that one so long. Yes,
Joe,
sir.
Joe, you mentioned that physicians don't like to be managed, and I would tend to agree with that. How do you get physicians aligned and fired up about what the future looks like, with, aside from paying them bonuses for performance or outcomes?
How do you get physicians aligned and fired up about the future, aside from paying them pay for performance bonuses? Well, that is a real core question. That's why Abu Dhabi is having me come back. They signed me up for a 4-year contract after I came down and gave a talk about physician alignment and empowerment. One key to it is, what doesn't work is to put them in a group and then have the suits tell them what to do. Or have someone that's not them, even if it's physicians that are not their group, tell them what to do. Ideally, when you put physicians together in a group and you try to drive them toward less expensive but higher quality care, you incentivize them in a way that they can figure out as a group, as a physician-led group, what is best for their patients in their situation. I've seen a lot of physicians get excited about that kind of thing, where they're now being given the tools and the incentive to do basically the kind of care that they always thought should be done, but you're paid to just do like these little 9-minute or 7-minute meetings with patients. You're not paid to call them up at home or to figure out why they're not being compliant. You're not paid for that. So how can you do it? But now you're in a new situation where you're getting paid to do it, and people are actually asking you, please, how can you manage these patients better so that you make more money? This is, people sometimes complain that I talk so much about money incentives, but you flip it around and look at it the other way. If a doctor or other clinicians know that this is best for their patients, do it this way, but you're not paying them to do that, in effect, you are penalizing them for doing good medicine. You are in effect saying, yeah, you can do good medicine, but your income is going to drop by half. Why would we do that? That is what we do in typical fee-for-service medicine. We penalize doctors for doing the best thing. So we really need to look at the incentives and giving them the power to lead the change. There's one more woman over there that she looks like she's like really has a great
We'll
question.
take one more.
Thank you for the positive comments about primary care. One of the issues that I see, young doctors are coming out of medical school with huge, huge, huge debt.
Yeah.
If I'd had $150,000 in debt when I graduated medical school, I don't know what the heck I would have done.
Absolutely.
I would not have done primary care.
Yeah, absolutely.
And we are seeing fewer and fewer people go into primary care. So how do you match that with this whole change? I mean, I applaud what you're talking about because I think it really is the answer, but we have to find some way to pay people for thinking, not just doing.
Yes, absolutely. I think, I don't tend to talk about politics and government policy. That's kind of not so much my area. And there are lots of ways in which you could do lots of things. This is one area that I think as a country, we are all right with paying for things that are kind of the basic infrastructure, interstate highway system, ports, airports, taxes should pay for that. I think that medical education is part of the undergirding infrastructure of the country. I think medical education should be free. And then we should have rigorous, I mean, it doesn't, on the scale of things, medical education across the country does not cost that much compared to the other things that we plow into healthcare. I think it should be free, paid for with taxes, and then there should be rigorous, it should be hard to do, hard to get into, and hard to pull through it. And I think it would be reasonable to say that there is some national service that doctors need to do after they graduate to give back for it. I think it should be a national system, just like our national defense is that way. And then the doctors can go on their way with no debt. And because a lot of doctors, they just want to have a decent life. They don't want to get rich. A lot of doctors, they would be perfectly happy to be a primary care physician, not in a big metropolitan area. They'd be perfectly happy if they could afford it. So that's my thought on that.
All right. Well,
thank you very much for your time.
Thank you.